Bismillah ar-Rahman ar-Rahim. Challenges and advances in rosacea management. Rosacea is a common condition characterized by symptoms of facial flushing and a spectrum of clinical signs, including erythema, telangiectasia, coarseness of skin, and an inflammatory papulopustular eruption resembling acne. Subtypes based on specific clinical signs, and it is done by the National Rosacea Society. Erythematotelangiectatic type, papulopustular type, phymatous type, ocular type, and other variants like granulomatous type has also been presented. These are the subtypes: erythematotelangiectatic type, papulopustular, phymatous, ocular types. What about the prevalence of the disease? From 2.2 to 22%, average of 10% of general population. It is more prevalent in women, although impacted men have more disfiguring skin changes. Patients often present between 30 to 50 years of age, but manifestations can occur throughout the life course, given up that a third of patients has a positive family history of the disease. Differential diagnosis: perioral and periorificial dermatitis, acne vulgaris, seborrheic dermatitis, contact dermatitis, and also lupus erythematosus. Etiology and pathogenesis. Rosacea pathogenesis includes dysregulation of innate immune system, neurogenic pathogenesis, microorganism Demodex folliculorum, ultraviolet radiation, and abnormal barrier function. So is it a one disease? While the etiology of rosacea remains unclear, and despite clinical heterogeneity, basic science has developed a possible unified understanding of the condition. It is an inflammatory disorder in the context of altered innate immune response. It is proposed that environmental changes, which may include ultraviolet light exposure, hormonal balances, microbial changes by pathogens such as Demodex folliculorum, and are sensed by a pattern of recognition receptors of the immune system. Subsequent signaling induced effector molecules such as reactive oxygen species, cytokines, and chemokines may then modify dermal structure through vascular changes, collagen degeneration, lymphohistiocytic infiltration, and neutrophil recruitment, which may perpetuate this response. Given this model, it is clear why most current therapies attempt to modulate various points of this inflammatory cascade. Antimicrobial peptides, which act as an antimicrobial defense mechanism, are actually present normally in the skin. One of them is the cathelicidin. We have only one cathelicidin gene that encodes many multifunctional peptides. This cathelicidin gene will give the one inactive propeptide with the serine protease kallikrein 5 or 7. It will be converted to the active form LL37, then into multiple small peptides with various functions, which leads to angiogenesis, cytokine chemokine release, and chemotaxis. There is a study that shows the cathelicidin expression is high in the keratinocytes of rosacea patients, and also the processed various peptides fragments of the cathelicidin is also highly expressed in the rosacea patient's skin. Another one is injection of cathelicidin fragments causes skin inflammation and erythema in mice. So the current model of rosacea pathophysiology, environmental triggers like ultraviolet light, sun exposure, heat, corticosteroids and hormones, and microbial as Demodex folliculorum, sensed by sensors, pattern recognition receptors like toll-like receptors lead to effector molecules, cathelicidin, proteases, reactive oxygen species, cytokines and chemokines, This leads to some consequences like vascular changes, collagen degeneration, inflammatory infiltrate, and neutrophil recruitment, given the clinical picture of rosacea. Psychological factors. Furthermore, the relationship between the psychological factors and rosacea remains to be elucidated. 75% of the affected patients report low self-esteem, with a significant odds ratio of 4.81 for diagnosed depressive disorder in the population compared with general population. The use of validated assessment tools has demonstrated the impact of rosacea on quality of life and, importantly, the improvement in the psychological indices that can occur with treatment. Treatment. Before the initiation of therapy, the triggering factors that exacerbate patients' rosacea should be identified and avoided if possible. Common triggering factors include the following: hot or cold temperature, wind, alcohol, emotions, caffeine, exercise, spicy food, topical products that irritate the skin and decrease the barrier, medications that cause flushing, and hot drinks. Now we will talk about the FDA-approved treatment for rosacea. Bromidine tartrate, Mirvazo by Galderma, for facial erythema. Ivermectin, Solantra, for inflammatory type of papulopustular rosacea. And Metronidazole, Rosacea gel. And also for papulopustular rosacea, doxycycline, 40 milligram capsules, Oracea, for papulopustular rosacea, and azelaic acid. Azelaic acid for papulopustular rosacea. Sodium sulfacetamide sulfur, and the lately FDA approved or newly approved topical medication for rosacea patients, oxymetazoline, for the erythematous telangiectatic rosacea. It's approved in 2017. We will talk about the topical treatment first. Topical metronidazole. Topical metronidazole has been used in treatment of rosacea since the 50s. There is no statistically significant difference between the two concentrations of topical metronidazole, 0.75% or 1%, and also of different types of the cream, gel, lotion. They are all the same. All are effective in maintaining remission as well. Among available topical therapies, metronidazole has also been proposed to be the most cost-effective regimen, which may be an important factor for some patients. Topical azelaic acid. Azelaic acid is a naturally occurring saturated dicarboxylic acid approved for the treatment of mild to moderate rosacea. Patients using azelaic acid showed improvement of 70 to 80% of the rosacea compared to 50 to 55% in the placebo group. Azelaic acid 15% gel administered once daily has demonstrated equivalent efficacy to twice daily application, although the recommended dosing is twice daily. Metronidazole versus azelaic acid. In two studies comparing topical metronidazole and azelaic acid, there was no statistically significant difference between the treatment groups with respect to patient-assessed outcomes. However, in the split-phase comparison clinical trial by Medin, patients favored the outcome of azelaic acid. In both the Medin and Inveski et al., the investigators were of the opinion that treatment with azelaic acid was more effective than metronidazole, but actually, in the studies, they are the same. Systemic therapy. Sub-antimicrobial low-dose oral doxycycline. Tetracyclines, pregnancy category D, have been a mainstay of rosacea therapy for more than half a century. However, a clear bacterial pathogen has not been implicated in the pathophysiology of rosacea. Furthermore, standard antimicrobial dosing may affect endogenous flora and risks the development of antibiotic-resistant strains. In light of these considerations, tetracyclines have numerous anti-inflammatory properties thought to be responsive for their efficacy in the management of the rosacea. They suppress neutrophil migration and chemotaxis inhibit angiogenesis and activation and proliferation and migration of lymphocytes, block production of matrix metalloproteinases, and upregulate anti-inflammatory cytokines. Anti-inflammatory low-dose doxycycline 40 mg capsules formulated as a 30 mg immediate release and 1 mg delayed release beads and dosed once daily provide a sub-antimicrobial dose that reduces the inflammatory response without producing drug concentrations required to treat bacterial diseases, thus avoiding concerns regarding selective pressures generating microbial resistance. The efficacy of the oral doxycycline 40 mg capsules once daily in the treatment of adults with rosacea was demonstrated in the 2 large randomized double-blind placebo-controlled multi-center trials assessed after 16 weeks of therapy. Doxycycline 40 mg provided a significantly greater reduction in the total inflammatory lesion count primary endpoint than placebo, rapid onset of action with a significant greater decrease in the lesion count than placebo by first follow-up at 3 weeks in both studies. Interestingly, maximum anti-inflammatory dose appears to be achieved with doxycycline 40 mg once daily. In a small randomized double-blind trial, no additional improvement in rosacea symptoms was achieved with oral doxycycline 100 mg once daily. The treatment was generally well tolerated by patients. Adverse events experienced only by 4% of patients were of mild to moderate intensity, with headache, nasopharyngitis, and GIT side effects reported most frequently. No photosensitivity was observed. Doxycycline 40 mg capsules have demonstrated a safe and effective monotherapy for rosacea in both males and females and in patients of all skin types. Further, patients reported improvement in symptoms, reduction in the interference of symptoms with life activities, and satisfaction with treatment. Combination therapy with doxycycline 40 mg capsules versus plus either azelaic acid gel 15% or metronidazole gel 1% were also safe, efficacious, and well tolerated. Emerging therapies. Ivermectin, a new topical formulation of the acaricidal compound ivermectin. Although the exact pathophysiology is yet to be elucidated, one well-known hypothesis of the etiology of rosacea is the presence of Demodex mites in the pilosebaceous units of the affected individuals. Reports have been published on cutaneous demodecidioses responding to oral ivermectin and topical permethrin, but data are now promising on the topical application of ivermectin alone. Stein et al. Reported in 2014 that ivermectin 1% cream was safe and effective for the treatment of inflammatory lesions from papillopapular rosacea based on 2 randomized controlled double-blind identically designed studies of ivermectin 1% cream versus vehicle applied once daily for 12 weeks. Several case reports have described successful rosacea treatment with acaricidal agents. Recently, a 12-year-old girl with Demodex folliculorum associated rosacea has had complete resolution of her symptoms following a single dose of oral ivermectin. These are the studies. As we can see, the baseline, the lesion count is 63, and at week 13, the lesion count is only 2, marked improvement. This is another study. The primary endpoint, mean percent change in the inflammatory lesion count. We can see the with the ivermectin and the metronidazole, we can see that the ivermectin is superior to metronidazole from the baseline until week 16. What about the side effects of Soolantra or ivermectin? There are possible side effects. Common, 1 to 10 people, burning feeling of the skin. Uncommon side effects that affect 1 to 1 in 100 persons. Irritation, itching, and dry skin. Not known side effects like redness of the skin and inflammation of the skin. How can we avoid these side effects or decrease it? by teaching the patients how to use and apply the cream, only a very small part that is applied to the 5 parts of the face. And also sometimes we advise the patients to put the Solantra in the fridge, and also we advise them to mix it with bepanthen cream so that we decrease the irritation, especially in the beginning of application of the cream. In addition to the agents listed below, anecdotal evidence indicates effective treatment of rosacea with medications that reduce flushing, including beta blockers, clonidine, naloxone, ondansetron, and selective serotonin reuptake inhibitors. Oral contraceptive therapy has also been helpful in patients who provide historical information of worsening of rosacea with their hormonal cycle. Dapsone has been used in severe refractory rosacea, and Dapsone is especially beneficial for patients who cannot take isotretinoin. Brimonidine and oxymetazoline, novel therapies to treat the erythema associated with rosacea, have been developed and have the potential to fill the void of arsenal of rosacea therapeutics. Brimonidine tartrate and oxymetazoline, which have potent vasoconstrictive activity and anti-redness capabilities, were first found in eye drops of glaucoma and nasal decongestant sprays, respectively. Brimonidine tartrate and alpha-2 agonist, mirvazogel. The mechanism of action: 1,000-fold more selective on alpha-2 receptor. What about the Mirvazo studies? Brimonidine tartrate, an alpha-2 agonist, has shown in a 2-part dose-finding phase 2 study to be safe and efficacious in reducing the erythema of rosacea. A single application of 0.5% gel reduced erythema between 30 minutes to 12 hours, as measured by objective chromometer. In a part B of the study, 2 dosages, 0.18% and 0.5% of the gel, was compared to vehicle over a 4-week period in 269 subjects. No tachyphylaxis, aggravation of symptoms, or rebound erythema was observed. The majority of adverse events were skin-related and mild and transient in nature. The 0.5% gel once daily was significantly more effective according to both patient and clinician assessment. Oxymetazoline is a potent alpha-1 and partial alpha-2 receptor agonist. It has been shown in case reports to be an effective agent for reducing facial erythema, and it has been formulated into a cream and currently approved by FDA for the treatment of erythematotelangiectatic rosacea. Other treatments available for more than 50 years: topical sodium sulfacetamide 10% and sulfur 5% was also being demonstrated to be significantly reducing the erythema, the inflammatory lesions and facial erythema compound to vehicle. However, the quality of studies evaluating this therapy have been generally poor. Systemic isotretinoin also has been used off-label treatment in patients with severe rosacea. A randomized double-blind trial comparing the use of different dosages of oral isotretinoin, both doxycycline and placebo, found isotretinoin 0.3%, 3 mg per kilogram, 0.3 mg per kilogram has an effective therapy for with a similar safety profile as for treatment of acne. Various topical regimens, including antibiotic and tretinoin preparations, has also been proposed. A recent randomized double-blind placebo-controlled study assessing combination gel of clindamycin phosphate 1.2% and tretinoin 0.025% has no difference in papule-pustule count, but mild improvement in telangiectatic component of rosacea was observed. Although not FDA approved for the management of rosacea, a randomized double-blind vehicle control trial was demonstrated the efficacy and of once daily topical benzyl benzoate 5%, clindamycin 1% gel in patients with moderate to severe rosacea. Common adverse events including pruritus, burning, and bleaching of hair and clothing. In a randomized, controlled, single-blind, split-phase trial of patients with erythematothelangiotic rosacea, both pulse dye laser and intense pulse light treatments were found to have similar efficacy and safety. An open-label uncontrolled trial of calcineurin inhibitor, pimecrolimus 1% cream, suggests that it is effective and well tolerated for mild to moderate inflammatory rosacea. A small single-center randomized study found pimecrolimus 1% cream to be effective as metronidazole 1% cream. The use of oral zinc sulfate has been also proposed for the treatment of rosacea. However, a randomized double-blind trial of 220 mg zinc sulfate dosed twice daily showed no difference in the significance in the magnitude of improvement between subjects receiving zinc therapy versus placebo. Although there is another study where they give 200 mg 3 times daily and it was effective. Due to the chronic nature of the condition, patients frustrated with the medical therapy may turn to marketed botanicals and herbal remedies in hopes of improving of their and control of the disease. Although there is a paucity of data surrounding the effects of these medications or cosmeceuticals, the clinician should be aware of products that may be used by patients, such as niacinamide, furfurfu, turmeric, colloidal oatmeal, and quassia extract. Conclusion: with the advent of novel therapeutic options for the treatment of rosacea, such as antimicrobial, anti-inflammatory dose of doxycycline, ivermectin, and bromelain tartrate, there is renewed interest in the study of this chronic inflammatory condition. There is ongoing need for well-designed, high-quality studies of widely used treatment for rosacea, including isotretinoin, sodium sulfacetamide sulfur, and light-based therapies, also pimecrolimus and other therapies. Lifestyle interventions such as avoidance measures for triggering factors, the use of sunscreen, dietary changes, and patients' education is an additional area of needed studies, and it would be beneficial for outcomes in the future trials to be based on validated standardized scales assessing both efficacy and improvement of quality of life. Where possible, therapeutic decision-making should take into account high-level evidence and to be guided by the clinician experience, individual patient characteristics, and preferences until further evidence is available. Thank you.